Hello, everyone, and welcome. We will get started in just about a minute. Okay, we still have a couple people hopping on, but we're going to get started. Hello, everyone, and welcome. Today, our webinar is Spotlight on Scott County, Indiana, how a small community made a big impact with harm reduction efforts. Our speaker today is Dr. William Cooke. This webinar is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The opinions expressed in this webinar are the views of the speaker and do not necessarily reflect the official position of DHHS or SAMHSA. The ATTC network believes that words matter and uses affirming language in all of its activities. I have a couple housekeeping details for you. If you are having technical issues, please individually message either Christina Spanbauer or Stephanie Bellman in the chat section at the bottom of your screen, and they'll be happy to help you. We will be using auto transcription during the training today. And if you have questions for the speaker, please put them in the Q&A section at the bottom of your screen as well. This presentation will be recorded and the slides in the recording will be available on the ATTC website within about 2 weeks. CEU certificates will be sent to all who attend the sessions, and it normally takes about 7 to 10 days. I apologize, it's not 3 sessions, it's just 1. And we will also send you, or you will be directed to a very brief survey at the end of this webinar. We'd really appreciate it if you could take it. It takes about 3 minutes, and it's how we report back to SAMHSA. If you'd like to see what else we're up to, please follow us on social media. And we are very excited that we have Dr. Cooke as our presenter today. Dr. Cooke is a fellow of the American Academy of Family Medicine and American Society of Addiction Medicine, specializing in family medicine, addiction medicine, and HIV medicine. His work has been covered by CBS, NBC, PBS, the BBC, USA Today, the New York Times, NPR, and many others. His book about the 2015 Scott County HIV outbreak, Canary in the Coal Mine, will be released in a few weeks. And I'm going to turn it over to you, Dr. Cooke.
All right, thank you so much for joining us. And I'm going to try to rewind this so we can get started. I'm going to go ahead and start by just reading part of my book from the introduction. I think it kind of highlights what we're talking about here. So just from the introduction, it says the COVID-19 outbreak that gained momentum throughout the United States in 2020 highlights how socioeconomic and racial disparities impact the health of people. This fact goes beyond genetics or limited access to medical care. The roots of disease can consistently be traced along the tragic history of toxic stress, experienced often generationally by marginalized and impoverished people. Socioeconomic stress has been well established as a contributing factor in the development of chronic diseases like diabetes, heart disease, and asthma. According to an article in The Lancet, the negative consequences of health disparities in the United States were already a problem before the pandemic. The article goes on to explain that the sickness and death resulting from COVID-19 disproportionately affects already vulnerable US populations. The deeply rooted social, racial, and economic health disparities in the country have been laid bare. In other words, COVID-19 simply put the already existing problems in sharp relief. My patients in Scott County taught me how devastating these health impacts of socioeconomic hardships can be. In March of 2015, I was the only doctor in Austin, Indiana, a city of 4,300 people in Scott County, just off I-65, between Louisville, Kentucky, and Indianapolis, when it became ground zero of two unprecedented healthcare disasters that have roots dating all the way back into the 1980s. One was the national opioid epidemic. The other was the worst recorded HIV outbreak among people who inject drugs in US history. These two deadly epidemics that had been brewing alongside each other for decades finally boiled over in Austin. Whole families were injecting prescription painkillers together. And since state law made sterile syringes so hard to obtain, desperate people locked in a deadly dance with addiction resorted to sharing syringes and with them diseases. Within a few months, our HIV incidence climbed to one of the highest globally. Experts, researchers, and journalists flocked to Austin from around the world. But since no one had ever seen anything like what was happening in my small town, no one knew what to do. I told reporters that this was not a freak occurrence. The conditions that made Austin ripe for this crisis existed in towns all across America. We had to act immediately and decisively to prevent other communities from being harmed. And I told Dean Reynolds on CBS Evening News, as we walked through the hardest hit areas of Austin, that I've described this community as a canary in the coal mine. This could happen anywhere because we're all Austin. I grew up in Southern Indiana, and my family actually came out of Appalachia along the Hillbilly Highway, just like a lot of my patients did. So I grew up in similar socioeconomic environment that a lot of my patients did. And in growing up that way, you have limited access to resources and opportunity. But one thing that I did have access to was parents that loved me. I never questioned that. I always felt supported. I always felt loved. I knew they were there for me no matter what. And, I can't say enough how important that was to me personally. My mom, however, describes a home that was a lot different than my home life. And what she describes to me, is very similar to a lot of what my patients describe to me on a daily basis when I'm working with them. And that's a home that's filled with toxic stress, with drug use, with alcohol use. She never really felt, real connected to her dad. Her mom tried the best that she could, but just like generations of people in her family, she dropped out of high school. She got married at 16, dropped out of high school, didn't finish high school. Nobody in her family finished high school, just what you did. You drop out, you get by the best that you can. Fortunately, she married a man who truly did love her, and his family, my dad, was a little different. They were poor, but they were very much connected with each other and supported each other and loved each other. and she got access to that through him. And she said it really changed how she saw things and how she had a different outlook in life. They also joined the military, where she had a lot of structure and environment. But my Aunt Sally, she never escaped that. And unfortunately, she went on to die from a drug overdose at the age of 39. This is her grave with my mom there. So what I learned growing up was that I was loved, but I didn't have sometimes the resources and opportunity that some of my friends had. In high school, I can remember all of my teachers telling me to work harder, to try harder, try harder, try harder. And I didn't know what that meant. I felt like I was trying really hard. I wanted to do well, but I didn't really understand how to do well. My mom had dropped out of high school. We were poor. We didn't have a lot of access. But in everything that I did, I always tried my best. I always tried harder, but there was something keeping me from really, being successful. When I went to college, my parents really pushed me to go to college. They wanted me to have the education that they didn't receive. And because of my dad's military service, I was able to do that on a veteran scholarship at our local community college. But even there, my professors were still telling me, you need to try harder. And I felt like I felt like I was trying really hard, but I didn't understand what they meant by that. But finally, I started interacting with my fellow students from higher socioeconomic status, and I started learning how to take notes, how to study, how to prepare for exams, those sorts of things. And all of a sudden, all that effort that I had been putting into school and studying started to pay off. And from my junior and senior years in college, I got all straight A's. Eventually got into medical school, got all honors during medical school, graduated with honors from IU School of Medicine. Went on to residency to open my practice in Austin, Indiana in 2004. And what I found there was not something I was expecting. It really was a perfect storm of this really terrible opioid crisis that I identified immediately after opening the doors to my clinic. Patient after patient just kept coming to me looking for OxyContin, looking for Soma and Xanax, and I wouldn't prescribe those to people, but I would work with them and try to figure out how to help them in their life. But they were experiencing these overwhelming demographic circumstances that a lot of the people I was working with didn't feel like they had the resources and opportunity to overcome. And then combining with that, there were public policies in place which prevented people from having access to harm reduction to reduce their risk of developing diseases and the consequences of what was going on there. And eventually hepatitis C came into the community, and HIV, as we mentioned. So Scott County is in southern Indiana. It's right off I-65, like I mentioned, that goes through Louisville, through Indianapolis, up to Chicago. Scott County has about 2,400 people that live there. Austin, Indiana is a town of only about 4,300 people. And that was the center of the HIV outbreak, is Austin. We did not have access to addiction services or mental health services. As you can see, Indiana was ranked near the bottom in the country for access to addiction specialists and behavioral health specialists. And in Scott County, that's even worse than the overall already bad numbers that Indiana was putting up. And again, local harm reduction was really not available. There was no access to clean syringes. Sex education in Scott County was abstinence only. There wasn't a lot of money available for the health department to do screening and education and connecting people to resources. It was really, this mirrors what it looks like in a lot of rural areas all across the country. So what we found out was that about a quarter of the people in Austin were misusing prescription drugs in a non-medical way, about a quarter of the population. And about 15% of the population were actually injecting drugs. And because, these practices were illegal and highly stigmatized, people, were hard to find. They didn't want to be known. They were living in the shadows. They wouldn't tell people, I'm injecting drugs, I need help. They were scared to do that. And because it was illegal, they mostly hid their behavior from other people. I met this young woman named Samantha within the first few years of opening my practice. She came to me after having back surgery and was experiencing chronic pain in her back. She had been going to a doctor who was prescribing her Lortab, and was looking for a doctor that might be able to prescribe that closer to her. I wanted to help her, and I talked through that with her and let her know that if she would work with me, with the emphasis to move towards getting off of the Lortab and to regaining function in her life, that I'd be willing to do that. And so she said she would. I got a drug screen, got records, went over all that with her, made sure she wasn't taking anything else, had her sign a contract. She was good with all that. And that continued for several months. And I felt like we were moving in the right direction. She was doing physical therapy, and I felt like we were helping her. And then one day, a drug screen that I did on her came back with other substances in it besides what I was prescribing her. And I'm embarrassed to say this, but at the time, it was pretty common practice to just send somebody a letter in the mail, letting them know that you were basically firing them from your clinic. And so that's what I did. I sent Samantha this letter in the mail, letting her know that she had broken her contract with me and that she was no longer, a patient of mine, and went on with my business. And a few days later, she came to the receptionist window with my letter, and my receptionist opened the window and she threw my ripped up letter into my receptionist's face and said, "Dr. Cooke cut me off. I need help. I need help. What is he going to do about this?" And, my receptionist came and asked me, and I, at the time, like I said, through medical school and residency, we were trained that, if somebody is addicted to drugs, they're going to have to hit rock bottom before they're going to get help. And there's really nothing you can do for them. And she had broken her contract with me. And so that's what I told my receptionist to tell her. And so when my receptionist told Samantha that we weren't going to be able to help her, she just started screaming and tearing posters off the wall, turning over furniture. And luckily there wasn't anyone in the waiting room, but we called the police. The police came and got her, put her in the police car. And I'm looking out the window, and it just dawned on me how much she reminded me of my Aunt Sally at that moment. And remembering that she had been arrested over and over again from going to different doctors and getting pain pills. She and my grandpa even had this scheme where she bought him a walker from a yard sale, and my grandpa would go to doctors in the walker and convince them to give him prescription drugs, and the two of them would sell, the leftover drugs to make some money on the side. And I'm looking at her just thinking about my Aunt Sally, and knowing that my Aunt Sally eventually died at 39, way too young. I felt bad for her, but I really didn't know what to do to help her. I was, this was 2006, and I had just finished my residency in family medicine, and there wasn't a lot of emphasis on harm reduction or addiction or how to help people in that situation. And so I just went on with my practice. But I did take that moment to try to start educating myself. And I remembered that my dad eventually went to college and was studying in the psychology department. And I remember as a kid, he would take me to some of his lab work, and he would tell me about some of the stuff that he was learning. And one of the things that he was learning was Maslow's hierarchy of needs, and was doing experiments on monkeys and showing that when monkeys' needs aren't met, they are not able to function and socialize with other animals, and they die early, and they have disease. And so, I started to realize when people's basic human needs and safety needs aren't met, when they don't have a sense of belonging, or then when those things aren't met, they really have a hard time of caring for themselves and caring for others, where that esteem part fits. And then there was really no drive to do anything more with pursuing cognitive opportunities or seeking art and beauty in the world, and eventually reaching self-actualization and then transcendence, where you're trying to do something above yourself and beyond. And I realized that there's this town that I'm trying to work with that has been experiencing generational trauma, and there's these social conditions that are outside of their control that appear to be overwhelming to them, resulting in toxic stress and adverse childhood experiences. And what I started learning through some research is that this sets up, somebody that's growing up into that, it really disrupts their neurodevelopment and leads to social, emotional, and cognitive impairment, leading to risky behaviors. The frontal lobe is affected to where higher executive thinking is disrupted. So you're making, poor choices. Memory is affected, so you have trouble learning. There's post-traumatic stress that's built into theirs too. So you're very distressful. And this leads to diseases, disability, social problems, and eventually early death. So as I started realizing this, I was seeing it alongside that in my patients. And one, glaring example of this was the number of women that I was diagnosing with late stage cervical cancer. And with screening, no one should ever develop cervical cancer, let alone die of cervical cancer. And there were several women who I had to give the terrible news to, that they had metastatic cervical cancer, and then end up watching them die. And that should just never happen. And to have that happen in the richest, wealthiest nation in the world that has all these resources available to people, it really struck me. And I realized that we were doing harm to people. And you could consider this violence. And yeah, there's direct violence where, it's very visible, it's very aggressive. And somebody punches somebody or stabs somebody, and that's a direct violation of their agency, their personhood, and that's harming them. And we see that very directly. But there's also cultural and structural violence that's a little bit, it's under the surface. We don't really recognize that as violence sometimes. But when we condone behaviors that harm people, when we justify systems that are in place that harm people, that's cultural violence. And those systems that are put up in people's lives and in communities that prevent people to have those resources and opportunities that they really need to be healthy, prosperous, and have well-being. If there are structures in place that prevent people from advancing in life, that's actually structurally violent to those people. Not having reliable transportation, not having humane housing, not having access to healthcare because of insurance issues, or that there's just not a doctor's office in your town. My office, when it opened in 2004 in Austin, was the first medical access that people had on a reliable basis since the mid 1970s. So an entire generation had grown up without medical access. So I was identifying that there are circumstances beyond people's control that is setting up a structural system that's violent to people, and seeing and burying young women with cervical cancer was a glaring example of that. And this slide, I think, shows that even more with all of these issues that get in the way of somebody's efforts of trying really hard to move their life in a positive direction, but they're pushing this huge boulder uphill against poverty, against poor housing, against unemployment, against inadequate food and nutrition, and lack of education, environmental factors. I think that slide really shows that well, and what I was seeing in the lives of my patients. And what I came to believe, and I'm trying to find this in research, but I have not found it yet. But I believe, agency is required in order for someone's behavior, for them to be accountable for their behavior. If you go into a courtroom, one of the things that the defense attorney may be trying to do is to prove that they were incompetent, or they weren't to be held accountable for their behavior because they didn't have agency. And agency, I think, requires that someone's basic human needs and safety needs are met, that they have this, that there are circumstances and opportunities that are required in order for somebody to have the opportunity and resources to make healthy choices, because people can only make choices of the options that they have available to them. If they don't have the option to make a healthy choice, can we hold them accountable to not making that healthy choice? I think the answer is obvious. If they don't have access to that healthy choice, how can we blame them for not making that choice? These things together are required for people to be able to access health, prosperity, and well-being. So I was also, seeing patients in the emergency department, and we were seeing the terrible outcomes from people using drugs and injecting drugs, and one of those terrible outcomes was people coming into the emergency department who had sepsis, this overwhelming infection in their body, where they had been sharing syringes or reusing a syringe that wasn't sterile, and injecting that straight into the bloodstream, and that bacteria would spread through the body, causing endocarditis, or causing septic emboli in the lungs, or just overwhelming sepsis. And I'll just read this section from my book again, because I think it's easier just to read it. So one night, after seeing a steady stream of patients with chest pain and abdominal pain, coughs, minor injuries, a panicked young lady rushed to the registration window with wide eyes and panic and screaming hysterically, "My sister needs help. She's too weak to get out of my car." Both of my nurses immediately rushed out and pulled this very frail 20-something-year-old female from the car. When we moved her from the wheelchair to the stretcher, she began to groan loudly and frantically flailed her arms around. We had no idea what was wrong with her, but based on the track marks we saw running up and down both arms, we had our suspicions. The nurses began to hook her up to the monitors and to search for IV access. "What's her name?" I asked, checking with the young lady, and looking for her vitals. A quivering voice in the corner of the room said, "Amber, she's my sister." I called to Amber loudly and asked, "Can you hear me, Amber? What's going on?" "Stop it," she replied, and slapped at the nurses trying to help her. I leaned in and turned her head to face me. "Amber, look at me. You're at the hospital. We're trying to help you. We need to know what's going on. Are you in pain?" "Everywhere," she nodded and groaned. Exasperated, one of the nurses looked at me and said, "She's used up all of her veins. I'm not getting anything." "Her blood pressure is 64/30, and her pulse is steady," said the other. I put my stethoscope on her chest and listened to her racing heart and rapid breathing. "She needs fluid," I instructed. "We can't get an IV, doc. She's blown out all of her veins," the first nurse repeated. I thought for a second. This young woman was critically ill. We had to have IV access to save her life. Amber's sister still stood quietly in the corner, looking frantically from one face to the other. I've been wanting to try that new IO device, I blurted out. Now's as good as time as any. Let's break it out. An intraosseous infusion is an effective way to rapidly give a patient large volumes of fluids and medications without having IV access by essentially drilling a needle into the bone directly and forcing fluids into the marrow. It's only used in emergency situations like this one because it's extremely painful. I'd undergone a bone marrow biopsy myself when I was 15, and even with a local anesthetic, it was excruciating. The nurse handed me a small electric drill similar to what I used on weekend projects around the house, and I attached a large needle to it. Holding the drill in my right hand, I felt for the bony landmarks just below Amber's left knee with my left hand. Satisfied I had the correct place, I forced the needle through her skin down to the bone and pulled the trigger. Amber unleashed a blood-curdling scream as the nurses strained to hold her still. Her sister cried out in horror, her hands covering her mouth and her nose. We quickly began to push fluids into Amber. It's what her body needed, but it didn't stop her from fighting back against the pain. The nurses held her down as she thrashed about, moaning, as the fluids pushed its way through the bone marrow, sending waves of pain through her body. Unfazed, I ordered 2 full liters to be administered as quickly as possible. Is something wrong? Her sister pleaded from the corner. Why is she in so much pain? Bone is exquisitely sensitive, I quickly answered without turning to look at her. I was too busy monitoring Amber's vital signs flashing ominously on the monitor and process my next steps. Based on everything I was seeing, she was severely dehydrated and likely septic, probably as a consequence of using a dirty syringe while injecting. She shouldn't have used up all of her veins, one of the nurses murmured knowingly to the other nurse. As the fluids continued to flow in, Amber's heart rate and blood pressure started to improve. I began to press under her right collarbone, searching for the landmarks where I'd place a central line. This meant inserting a large needle, several inches long, about the size of a cooking thermometer, into her chest to pierce one of the largest veins in her emaciated body. This would allow me more reliable intravenous access for fluids, antibiotics, and other medications that she needed. Amber winced and groaned as I sterilized and prepared the area around her collarbone. Just then, as I was about to insert the needle, a voice broke my concentration. You don't even care that you're hurting her. I had forgotten that Amber's sister was still there. I turned to face her. What? You're hurting her and you don't even seem to care. She wiped away a few tears streaming down her face. I heard you say that you were looking forward to using that drill on her. I was dumbfounded. I was doing everything possible to save her sister's life. Everything possible. I'm sorry, I said flatly, trying to keep the spot I'd identified on Amber's collarbone sterile. We're doing everything we can to stabilize her. Yeah, but that's my sister, she shot back, her tears flowing. And you're not even treating her like a person. That comment hit me like a bucket of water. I looked into Amber's eyes. Her sister was right. Amber was not just a drug addict suffering the consequences of irrational behavior. She was not a test dummy on which we were practicing our treatment algorithms. Amber was a person who was obviously cherished. She was this young woman's sister. Yeah, and so for that brief moment, reality's veil was lifted ever so slightly, and Amber became my Aunt Sally, and her sister my mom. And I remember one day while I was in college, Mom had raced to the hospital after being told her sister had been taken there after overdosing. My mom was met by Dr. Graves, a physician who my mom had worked with as a nurse. The sorrow was in his eyes as he told my mom that despite his best efforts, my Aunt Sally had died. We had to call it, the doctor told her. To call it sounded so cold given what had really happened. Mom had worked enough codes to know that Sally had been stripped naked to expose any injuries and to allow unimpeded access to her body. They shoved a tube down her throat to breathe for her. They performed chest compressions, if had done correctly, broke ribs. This was a violent, undignified way to die, just as drilling into Amber's leg bone was a brutal way to try to stabilize her. Yet neither Dr. Graves nor I had any choice. Breathing choked on a wave of emotion that washed over me as I imagined my mom pleading with me to treat her sister like a person. This young woman had every right to hold me accountable for my lack of compassion. Composing myself, I tried to explain, your sister desperately needs fluids, and this, I pointed at the IO sticking out of Amber's leg, is the only option right now. Can't you help her be more comfortable? I asked. She asked. Of course, I said, making sure that I was speaking gently. I turned back to the nurses. Go ahead and give her 50 micrograms of fentanyl. I looked at Amber's sister and said, that'll help ease some of her pain. Amber almost immediately relaxed and went back to inserting the central line, but her sister's admonition continued to echo in my mind. It still gets me. I realized that people who were suffering from this disease of addiction, substance use disorder, were just like all the other patients that I was taking care of with other diseases like diabetes and hypertension and heart disease, congestive heart failure, and cervical cancer. And they were suffering. The consequences of a structurally violent system. It wasn't their choice to be born or raised in a place like Austin. They didn't choose that, but they were suffering the consequences of that. And so I realized there were certain community factors that fostered health, wellness, and prosperity. And these are the factors that were recently released by the Surgeon General's report on community health and economic prosperity. In the middle, you have belonging and civic muscle on purpose, because that is the central piece that makes everything else work. But people really need meaningful work in order to be prosperous, fair wages for the work that they do, lifelong learning, an emphasis on finishing high school, and those high schools having trade programs to where they could be fully trained to do meaningful work on graduation, or college credits so that they can start achieving their dream of graduating college. And then even after that, having opportunities to learn after graduating, and starting that as early as possible, preschool programs, and getting people out of maybe some toxic environment at home to start learning. Humane housing. Without humane housing, nothing else really matters, because you're constantly focused on just surviving, and reliable transportation. If you can't get to school, to the clinic, to the grocery store, or wherever you're trying to go, you can't make those healthy choices either. And again, belonging is such a critical part of who we are. And so just like, I remember, growing up and just trying so hard to do well. One day I was out trying to start my lawnmower, and I just pulled and pulled and pulled. And I knew that if I tried hard enough, that dang lawnmower was going to start. And then all of a sudden, the cord broke, and I keep it on my desk. That's the actual cord I keep on my desk to remind myself that trying harder doesn't always give you the results that you're looking for. Without the system working, without that lawnmower being tuned up and fixed for whatever reason it wasn't starting, no matter how many times I pulled that dang cord, it wasn't going to start. No matter how hard I tried in high school, my teachers were going to keep telling me to try harder until I had the resources and opportunity for my choices, my hard work, to actually start paying off like they did in college and into medical school. And in the lives of my patients, the same thing applied. I saw people trying really hard to make good choices, to do better, to advance their families' lives, to care for their children. But that effort wasn't paying off because they were dealing with circumstances beyond their control that were so overwhelming that they couldn't overcome them. So about that time, Samantha showed back up in the emergency department. And I remember, she came in for abdominal pain, and the nurses thought, because she had told the nurses that she was dealing with some constipation. And, I figured she's still using opioids, and opioids leads to constipation. So it made sense that was what was wrong with her. I went in and talked to her, ordered some studies, was waiting for those studies to come back. And this young man came out and he handed me this letter that he told me that Samantha had been carrying around with her for a few years. This was after 2010 at this point. Let's see. So I started reading this letter, and it was basically telling me how she grew up in a home that she never felt loved. She was sexually abused by her father. Her mother wasn't around a lot, was using alcohol to cope with the tragedy of her life. I'll just pick up from part of my book there. And she said that when she was 15, her dentist prescribed her some pain medicine. She's discovered that not only did they take away some of the physical pain that she was experiencing, but they also made her feel safe for the first time in her life. I sighed. Once again, a patient reported beginning to abuse drugs because they were providing the security that they should have been getting from loved ones at home. Samantha said that she began to sneak pills from family members, and then figured out how to get them from doctors and dentists that would prescribe them for her. A boyfriend showed her how to get an even higher or more intense rush by crushing them and snorting them, feeding the drive of her pills even more. She was able to get a legitimate prescription after a back surgery, and by that time is when she came to see me. She had resolved to wean herself off of them, but by connecting to the wrong person again, she relapsed. She said, I was terrified that you'd find out. I should have just told you, but I didn't, and you found out anyway. When she received the letter from me in the mail, she freaked out and snapped, trashing my waiting room. She ended the letter this way: would you be willing to take me back as your patient? I don't want pain pills anymore. I just want help. Will you help me, please? I folded the letter and sat in silence. My heart broke for Samantha. I wasn't sure what I could do to help, but I knew that nothing would stand in my way from trying to help her. I'd let her know that I'd take her back when I went over the test results with her. I was confident that a laxative and less opioids would help her feel better. After attending to a few more patients, I sat back down at my desk. My shift was almost over, and I glanced over at Samantha's letter and allowed myself to relax a little with the thought that I'd have a second chance to show her the care that I didn't the first time. Just then one of the nurses poked her head around the corner and said, Dr. Cooke, the patient in room 8 scans are back. I thought you might want to look at them before you leave. I smiled, thanks, I told her, and I pulled the results up on my computer. No, God, this can't be right. I leaned in to take a closer look, but it wasn't necessary. The scan clearly showed a massive tumor beginning in Samantha's cervix that had eaten all the way through her rectum, completely obstructing it. The report was long, but the words that jumped off the screen at me were metastatic cervical cancer. I felt sick. Given the size of the tumor, odds were it had been silently growing there for years. If she had been receiving regular medical care, a routine pap smear could have identified it early enough to spare her the suffering. She could have gotten treatment. She would have been okay. Now, she probably only had 6 to 9 months at the most. What made Things even worse was knowing that I had participated in shortening Samantha's life by cutting her off from preventative care. How was that any different from the structurally violent system that limited life-saving and life-affirming care for the most vulnerable? So in 2011, we started seeing this huge increase in the number of people overdosing from drugs, as well as abscesses and an increase in endocarditis and hepatitis C. In 2012, an article was released in Reuters, and here's the article. It said, painkiller Opana, the new scourge of rural America. And it identified Opana as being one of the drivers of injection drug use throughout the country, but they identified Austin as a place that particularly needed help. What we saw after that was that Scott County down here ranked near the worst in the state for new cases of hepatitis C. So this further showed us that on top of the endocarditis and the sepsis and the abscesses, that injection drug use was going on, and people were actually transmitting this virus that was spread through the bloodstream through shared syringes, hepatitis C. And that is a harbinger for HIV. About this time, the Indiana State Department of Health issued a report saying that if something wasn't done, that we would start seeing an increased cases of HIV. And that's exactly what we ended up seeing. And this slide shows the number of people contracting HIV in that, that first line that's going up dramatically. And then when we started testing a few years later. So if we had the resources to even test people earlier, we could have caught it earlier and gotten people into treatment earlier. Or if there was a syringe program in place where people weren't sharing syringes, we could have prevented this huge curve, this tsunami that took over in end of 2014 into 2015. But we didn't. So one of the things that we rapidly tried to do was to develop those resources. So we started doing a lot of testing. I asked to get my staff trained to be able to do a local HIV clinic, which we started to do. So we started treating people for HIV and hepatitis C and getting them treatment. The syringe service program opened just after that. And as you can see, with the combination of treatment and the syringe service program, the new cases leveled off very quickly. We opened up the clinic there, and then we had the syringe service program. The incidence of HIV that year climbed to almost 5%, which is one of the highest, wasn't one of the highest in the world. So since 2004, when I had opened my practice, there'd only been about 5 documented cases in that 11-year span. And then in just that 1 year, we had 181 new cases of HIV. It represented a third of all the new cases of HIV in the entire state that year. It increased the number of people living with HIV by 20% in the state. This is the demographic breakdown of the people diagnosed. They were mostly young, mostly heterosexual, and most injecting drugs. The fact that there was only a few people with a CD4 count less than 200 shows that this was a new infection, as that they didn't have time to develop AIDS, which is what that's showing, and most people were co-infected with hepatitis C. Genetic tracings later showed that this was all traced back to a single person, and it was all within a few years of transmitting. The consensus was at the time that even if we were able to find the people living with HIV, because of their lifestyle, they wouldn't be willing or able to take their hepatitis C or HIV medications. And what I really learned from that was they were dehumanizing people and assuming that they were unwilling to engage in care. My patients that I was trying to work with were accused of being lazy, criminal, degenerate, and unintelligent. But again, they only had access to choices that they had access to. And without giving them the resources and opportunity to make healthy choices, I didn't feel like we should just sit around blaming them or saying that they wouldn't do what was right. Sadly, people were even advocating withholding life-saving interventions from people like Narcan. However, what I discovered was that working with marginalized people, even those that inject drugs, that there was really no difference between them or me or anyone else, that when they were approached with respect and compassion, and they were provided resources and opportunity in a way that felt safe to them, virtually all people were willing to take responsibility for their own health and the health of their communities. You might hear the word syndemic thrown around sometimes, and a syndemic is the concentration of deleterious interactions of two or more diseases or conditions in a location that leads to the promotion of disease clustering. And so, you know, when you have places that have this socioeconomic distress, these toxic stressors on people with lack of resources and opportunity, that's really setting up a scenario for a syndemic in that area. And what the CDC has talked about is that in syndemics, the traditional way of approaching people in need was to treat different diseases in parallel with each other. Really, we would treat one disease in one place, another disease in another, and focus on these different diseases. But in a syndemic, they're not separate diseases, but they're really tangled up together. And in order to care for people in the middle of these sorts of syndemic situations, we really have to have a synergistic care model that's, instead of treating diseases, it's treating people and wrapping those people in those communities, wrapping them with the care that they need in order to be healthy, prosperous, and have well-being in their lives. Really, the focus, needs to be on preventing, treating, and then moving people towards recovery. Treatment, we have a lot of different resources available, and one of the things I discovered is just trying to help my patients wasn't enough. Again, I needed access to the resources and opportunities to be able to make my efforts count. And so as this 2015 outbreak occurred, I started gaining access to the resources that I needed to really be able to help my community in need, my patients in need. One of those resources was Maytech, which trains providers to care for HIV and hepatitis C. GLATSI, which was amazing with getting us linked to the resources that we needed to address people with substance use disorder and to address the community factors that leads to substance use disorder, including ROS, which I'll talk about in a moment. Project ECHO, which is a brilliant program where instead of moving patients to specialists, you move the specialized information to the patients. And so each week I would meet with a group of specialists, including pharmacists and nurse managers and such, to talk through cases. And they would help me develop treatment plans that I could then go back and take care of my patients with. And so we didn't need an HIV specialist to take our patients to in Indianapolis or Louisville. Busing people seemed like a terrible model to me. But by working with these specialists, these mentors on a weekly basis, I was able to develop the expertise from an addiction standpoint, from an HIV standpoint, hepatitis C standpoint, to really be able to take care of my patients myself, and then pass that information on to my staff, my nurse practitioners, my physician assistant, to be able to replicate that even further and to expand our reach. There are training programs available for MAT, like buprenorphine, which is there. And then, of course, collaborations to be able to surround patients with all of the care that they would need. Wooded Glen opened recovery center where I'm able to admit patients to and see patients and help them. They can stay there we can detox them, stay them for a month. Centerstone opened a women's facility, get women off the street. Again, a 28-day program with transitional housing right there on site, where we can continue to take care of patients for months and make sure that they have all the resources that they need to be able to live a healthy life. The Indiana State Department of Health continues to partner with us to be able to provide the care that we need to people. AIDS Healthcare Foundation came in, provided me with a mobile unit so that we could get outside of the four walls of the clinic. I believe that, as a physician, I took the Hippocratic Oath, which says to do no harm, but to me, that seems very passive to wait for patients to come to me to not harm them. So I've rethought that, reimagined that to prevent harm, which requires me to go to where people are being harmed, which are outside of the four walls of the clinic. So having community health workers and a mobile clinic to be able to get outside of the four walls to do that was vital. This is Thrive, which is our recovery community organization. We didn't have any recovery support when the 2015 HIV outbreak occurred. If there's one thing that I will be the proudest of in my career, if I could accomplish nothing else, it's that I was successfully able to give a voice to people in recovery and to have them to drive the direction that we were going as a community, and to acknowledge and to empower them as leaders within our community. That's led to this recovery community organization that now doesn't just provide recovery services for Scott County, where we have nearly 20 recovery groups and peer recovery coaches that go out, but to, I think it's 20 different counties that surround Scott County. So that work is being done outside of our county now. Other amazing groups. This is Tom Cox. He was part of GLATC in 2015. He came to the first community meeting that I held in Austin on April 21st, 2015, asking the community to come together to define what it means to be in recovery and how to connect to people who are in the throes of addiction and withdrawal, to help them enter into recovery and to give back eventually. And he's the one that really taught me about ROSC and what that means. He worked with us closely over the next several years, helping us to achieve a lot of really amazing success. And unfortunately, he died a year and a half ago. But I just want to mention Tom Cox and just honor his name there. So ROSC, it's unique to each community. It's a recovery-oriented system of care. It's developed by the community because each community is different. It's going to look different in an urban setting than a rural setting, Hispanic community versus a white community, et cetera. And it defines what recovery looks like for that community. And it asks all the stakeholders from across the community, spanning from education to government to treatment to prevention, what recovery looks like for your community. And by having that shared definition and shared vision, everyone can then work together to help allow people to feel safe entering into recovery. And this is a video that was made about Scott County's ROSC.
People are approaching us and saying, you guys have come so far. Look at all the things that you've done. How did you get this place? And it was because of the people, the 5% that have the heart and the passion.
Now, when somebody comes with substance use disorder, I actually have medical treatment options to provide them, which is huge.
When they come in here, they get clean, they detox, they start speaking to counselors. They start seeing maybe there's a life or a vision for them after addiction.
There's just been an explosion of recovery groups in the county. We've gone from having 4 prior to the epidemic to now over 15. So, and they meet every single day of the week except for Sunday. And we're eventually going to have a 12-step faith-based one start on Sundays.
I've been in recovery for 1,155 days, which is a little over 3 years and almost 2 months. I was able to start working here locally where I used to get high, which is a big shock for people like me to come back to where you used to use and score your drug of choice at, and then to come back and to bring experience, strength, and hope to other people who are trying to get out of active addiction.
One of the main points of ROSC is that addiction is a disease, and if we could just get everyone on board with that instead of that addiction is a sin, and that these people are sick people and not bad people, that's huge. I am currently a peer recovery specialist with an inpatient treatment facility, the first one that I know ever in Scott County.
I grew up here and I used here. So for me to give back to this community that I once robbed means a lot to me. You actually get to see them come out of this horrible, negative place, and they just kind of blossom.
We started the very first Narcotics Anonymous meeting here in town, and since then we've had 2 more start up. If you're here and you're in this town and you can't quite get out, then like you need to find the people that are in recovery instead of your old people, places, and things.
The recovery community was like, what about painting a mural somewhere to kind of be a symbol to the community that, you know, hey, we used to only be known for the negative things, the negative ways we impacted a community. How about now that we're in recovery, we be known for a positive way that we can impact the community?
It's always good to have activities with other people in recovery, good, sober, clean activities.
It's just to show, you know, that a lot of beautiful things can come out whenever you're in recovery.
ROSC allows our community to have a conversation. It centers everyone around the idea of recovery. You know, they're starting to hear from other people that recovery is cool.
It feels good to help people when they need it, or just for my face to be out there and they know that there's hope.
It's going to start over. So, you know, harm reduction. It's, you know, it's thought of a lot in recovery and substance use disorder, but harm reduction really, I mean, it's reducing harm from any disease process. We do this all the time in medicine, and statistics show that less than 3% of Americans follow the recommendations of the CDC for a healthy lifestyle. Less than 3%. So what the rest of us, 97%, are doing, we're harming ourselves. And so we can reduce those harms by embracing what one of my all-time heroes, Dan Big from Chicago, called any positive change. Any positive change in someone's life is reducing harm in their life. So if somebody's smoking a pack of cigarettes a day, going down to a half a pack of cigarettes a day. If somebody is, very sedentary, they work at a desk all day, they go home, watch TV at night, just standing up at a desk instead, or walking around a few times a day, or going for a walk in the evenings is reducing harm in their lives. Shifting to a more plant-based diet is reducing harm in our lives. The same thing applies with people who are in the throes of substance use disorder. If we can keep people from using shared or contaminated syringes and using sterile syringes, that's reducing their risk of having endocarditis or contracting HIV or hepatitis C or developing sepsis and dying from from sepsis, keeping people alive that way, having community distributed Narcan, which, to me, it's very much like the Heimlich maneuver or bystander CPR. We get these life-saving tools out into the community where we can keep people alive because we can't help people who are dead. So having Narcan in the community is saving, thousands and thousands of people's lives. It's reducing the risk to our communities and our people. The faith-based groups in Scott County have really stepped up and it's helped a lot. We've developed a warm meal on Thursday nights. We have the Hope to Others Church. That's a safe place for people. One of the frustrating things as a Christian has been to send patients of mine to churches for help, only to have them come back and tell me that they were told that they didn't belong there and had never come back. I believe there's a place for faith-based groups, but that's a harmful thing to be told. And I try to work with people of my faith to try to help them understand that people need love and compassion and access in a way that feels safe to them. And when that happens, these faith-based groups can really do a lot of good work in a community. So, again, I described, our community as canary in the coal mine. There was a Lancet article that showed that Scott County, Indiana could have prevented over 90% of the HIV cases if we had simply been screening and linking people to care or having harm reduction strategies like syringe service programs in place, but we didn't. And so tragedy struck and the entire community suffered, the entire county. And Scott County is not unique at all in this. It's truly the canary in the coal mine. It's the warning to the rest of the nation that's dealing with this overwhelming crisis of opioid use. We see that last year, over 80,000 people died of overdoses, more than any other year on record. This is happening all across the country. And Scott County is not just the canary in the coal mine to warn of what happens when we don't pay attention and don't meet people's underlying basic human and safety needs and address the lack of resources and opportunity in people's lives and help them overcome those circumstances that they didn't choose. But it's also become a beacon of hope because we have had so much success going forward. What we've done is we've developed biomedical interventions combined with behavioral interventions and trying to address those underlying structural issues with structural interventions. That develops an effective paradigm. Looking at the structural interventions, trying to decrease inequality, trying to decrease stigma and discrimination, and that ROSC summit and definition has helped do that tremendously in our community. Better education for the public and for the youth. Our graduation rate has gone up. We've developed trade programs at the high schools. They can, people can graduate now with enough credits to get an associate's degree. That's helping with our people being better educated and able to have that meaningful work component, and then better laws to protect people. The Good Samaritan laws, where if you administer Narcan, you're not going to get prosecuted, for example, or having access to sterile syringes so that people can live without contracting HIV, hepatitis C, or developing endocarditis and sepsis. The biomedical interventions, increasing access to healthcare providers. Again, people who suffer from substance use disorder don't often feel safe accessing a healthcare provider. They're ashamed of what they do. And so allowing them to feel safe, having a peer specialist, connect with them and go with them to the doctor's office. That really helps in our community where we partnered with Thrive And the peer coaches will introduce with a warm handoff the patient to our healthcare team, having medication-assisted treatment available, embracing harm reduction in the community, doing screening, things like SBIRT, looking for substance use disorder, or testing for HIV and hepatitis C, and then protecting moms and newborns is such an important part of it. And then the behavioral interventions with educating people on what healthy lifestyles are and how to develop resiliency in your lives, and having therapists available to do cognitive behavioral therapy with patients, or dialectical behavior therapy with patients, having the social peer support groups and the peer specialists to go out into the community and to connect with people, to give them hope, and then just having access to employment. So when we focused on a patient-centered approach to the syndemic that we were facing in Scott County, a beautiful thing truly did happen. In just a few years, the number of people living in recovery has exploded by over 1,000%. We've partnered with 2 community health agencies and developed a one-stop shop at the health department where people can access things like health insurance, getting an ID, and the syringe service program where people who are injecting drugs that may not feel safe presenting themselves can at least go and get sterile syringes and start working with healthcare providers, building relationships, and eventually be able to come to the clinic to get help. What we've seen is that the number of people newly diagnosed with HIV have plummeted. That's the red line there. It's plummeted. The number of syringes going out, of course, it initially increased, but what we've seen lately is that it's starting to decrease. The number of syringes being asked for and going out is decreasing as the number, you can see this blue line going up, as the number of people accessing substance use treatment is going up. So it's working. It's working. Our viral suppression rates among very stigmatized, marginalized people who were, we were told would never take their HIV medications the right way. We have the best viral suppression rate in the state. Nobody is doing a better job of taking their HIV medications than my patients are. They're blowing the numbers away. Nationally, you can see here, only 49% of people, about half of people living with HIV are virally suppressed. We're pushing 80% of my patients being virally suppressed. So they're willing to take responsibility for their health and for their community if they're given the opportunity to in a way that feels safe to them. Before the syringe service program opened, syringe sharing, 74% of people were syringe sharing, and only 18% were disposing of syringes safely. After the program opened, the syringe sharing went down to 22%, and most people, 86%, were disposing of the syringes safely. So people who inject drugs that were accessing their syringe service program was 86% of people who inject drugs. But if you look at people who inject drugs that have HIV, that are living with HIV, it goes way up to 98%. This is further evidence that people want to do the right thing. They want to take care of themselves. They want to take care of their community. The reason that went up so much is the people living with HIV, they don't want to transmit the virus to other people. So they'll go get sterile syringes at a higher rate than somebody that's not living with HIV, because they want to protect the people around them. These aren't bad people that need to be locked up. They're good people. They're just living inside of a structurally violent system, battling circumstances that they didn't choose. So Indiana has led the nation for new hepatitis C cases, but if you look at the counties that have syringe service programs versus the ones that do not, hepatitis C cases are only increasing in the counties that don't have syringe service programs. So it works. Our cases in Scott County went from 243 in 2015 down to 58 and 2018, and they're continuing to do well. It's a decline of 76% of hepatitis C cases. HIV cases, have done the same. We went from having 181 that first year down to only one last year, one case. And if you had told me in 2015 that in 2020 you'd only have one case of HIV in the middle of the worst pandemic since 1918, I would never have believed you, but it happened. We only had one new case of HIV last year because treatment is so effective alongside of a syringe service program that's meeting the needs of the community. So communities, they don't fail because the people in them fail. They fail because we fail the people in the community. And we can't just keep painting over the cracks in the foundations of our communities and expect everything to look better without addressing the cracks in the foundation itself. Just banishing broken people isn't going to get us anywhere, but we need to banish the culture that forbids vulnerability and access to resources and opportunity. A broken system that puts barriers up to keep people from accessing care and from us being able to spend our time providing the very best care possible to people in need threatens to harm both the people that we want to help and us. We go into this work to help people, but we're at risk of being burnt out. Not because there's something wrong with us, but there's something wrong with the healthcare system and our ability to help people. And that's not being burnt out. That's moral injury. It's us being morally injured because we're not able to do what we know is best for our patients, to provide harm reduction, to give out Narcan, to allow people to have access to sterile syringes. So my challenge to everyone here today is to reject programs that solely focus on a disease or a single issue. Our patients are people with intrinsic value who are valuable to our communities. My guess is that you all, joined today and you're doing this work because you want to help people to thrive. And I encourage you, I know it's been a long year. COVID was hard on all of us, but we're coming out of it now. And I just, I challenge you to recapture that passion, to become advocates for harm reduction in your communities and for people that are in need in your communities so that we can have a person-centered response instead of just responding to diseases. By doing this, we're not just blaming drug addicts for being unwilling to take responsibility for themselves or harming our communities, but we're putting the blame on ourselves, really, and acknowledging that we hold the power to do something about this crisis that's rampaging our entire country. And rejecting and isolating broken people further, it just further weakens the foundations of our communities. We must instead acknowledge our own shortcomings and the shortcomings of our systems and take our place not over, but beside our neighbors who are struggling and trying to do better, to become part of something bigger and greater, a unified mosaic of imperfect people, all working together to create a thriving and healthy community. These are a lot of the people and organizations that have helped. There's too many for me to probably remember. So I just ask for forgiveness for those that I forgot to put on the slide. You mean everything to me. This has been quite a difficult time, honestly. But I really appreciate all the people that have come to help. This is Dan Big. He died a few years ago, but was really the patron saint of harm reduction. Was the one that really revolutionized syringe service program in Chicago, allowed for community distributed Narcan. So I want to acknowledge him and thank you all for listening. And I'd love to take some questions. As was mentioned, my book comes out in 2 weeks, June 22nd. Please go ahead and pre-order a copy. And I am available to do Zoom meetings with your organizations, churches, schools. I'd love to travel and speak on this topic. So if anybody wants to do book clubs or just talk about this more, I'd be happy to do that. But please order the book. It gives a lot of context to what we're talking about and some of those stories that I mentioned during the conversation. So please ask questions. And one of the things that I'm sure people are curious about is the Scott County Syringe Services Program. I will tell you, if you haven't found out, that our commissioners voted last week that as of January 1st, 2022, they're going to close our syringe services program. So we're having a meeting tonight. Our community is coming together to talk about what that looks like for us and how we might be able to transition to something different and still have access for people who are injecting to sterile syringes in a different way. And just to make sure that we're all continuing to collaborate so that our great story continues and we continue to have successes and not relapse into what was going on here in 2015. So what questions do you all have?
We have a couple, probably 3 or 4, but I'm sure more will come in as we go along. You are right. We have had a couple of people ask about what will happen now that the county has decided to stop funding the syringe program. And I guess it's a developing story. You'll all meet tonight and hopefully be able to come up with some good alternatives.
More to come.
And then another question was, what training program or organization did you use to support clinic staff in HIV screening, prevention, and treatment?
That's a great question. I hope the slides will be available to people so they can reference back to some of that. Maytech is a national, they're much like GladSea, there are regional centers. Maytech is specific towards HIV and hepatitis C. The ATTCs are specific to more addiction. Those two are fantastic resources. They can connect you to the world, really. And just knowing that they're there changed my life and changed our clinic. And being able to work with them over the years has been vitally important. The Project ECHO programs, those are invaluable. In medical school, at residency, we train by working with mentors and seeing patients, researching what to do for that patient, talking through that with a mentor, and then putting that treatment plan into place. And over time, you learn how to take care of people and address their needs. That's exactly what Project ECHO does on an ongoing basis. That lifelong learning piece that all people working in the healthcare field need. So there's Project ECHOs for HIV, hepatitis C, substance use disorder, diabetes, rheumatology. We developed a rheumatology clinic so that we can address people's pain needs without using narcotics and opioids. So now people can come to us sometimes on opioids, and we can move them off of opioids and treat their pain by connecting with this rheumatology team, which has been really successful for us. So there's a lot of different Project ECHOs that are helpful. And then I just reached out to different doctors that I knew to ask if I could use them as mentors from an infectious disease standpoint or for a substance use addiction standpoint. And so those resources were really valuable to me as well. But the people that we learned the most from were the people with lived experiences. And I can't stress more strongly how important it is to just listen to people's lives and hear the circumstances that they're bumping up against and the solutions that they can see that we may not be able to see, and allowing the people with lived experiences to really be the leaders, the teachers, in these sorts of situations.
Great, thank you. And one of the questions asked about Maytech, and there's they have a website, so you can go to that. Amanda put it in the, I will put it in the chat so that everyone has it. Nope, not it. Thank you, Stephanie. The other question was, did Scott County vote to end the program or just no longer fund it? And how do you, would you care to share your thoughts on politicians rather than medical providers making decisions on health?
Yes, and I'll try to choose my words carefully. So so in Indiana, just to talk through the state law a little bit, and every state is different, and many states don't allow syringe service programs or even the concept of harm reduction, restricting the concept of harm reduction as they did in West Virginia recently. But in Indiana, the law is that the local county or municipality has the decision on whether or not to allow a syringe services program to exist within their area. So for the county commissioners, they could vote whether or not to allow a syringe services program to be run within their county. Cities like Austin and Scottsburg could vote to allow them to operate within their cities. And so we are looking at that as an option, but the county commissioners voted to completely end the syringe services program the way that it currently exists as of January 1st, 2022. We are very appreciative that they allowed us that much time to look at alternatives. And again, one of the alternatives we're looking at is to work with the different cities to develop something that they're comfortable with, so that we don't lose access to that very, very difficult to reach group of people who would otherwise be off the grid, and we'd have a hard time connecting with them. Does that answer? I think that answers that question.
It does, thank you. And we have one more question is, can you talk a little bit more about stigma in the medical teaching and learning system? You mentioned things that you had to unlearn, like breaking up with that patient, and what barriers within medical structure for which we need to prepare.
Well, there's obviously still stigma that will probably be with us forever. No matter how much I talk about it, it seems like there's still people who insist on overemphasizing the personal responsibility aspect of addiction. And yes, of course, people make a choice to use a substance, but I challenge them with real world stories of young women who were started on drugs as a 8-year-old kid so that she wouldn't fight back when her father and his friends tried to have their way with her, and not knowing why she felt so bad as a teenager, withdrawing from those pills that he would either give her or inject her with. And I'm not talking, 1, 2, 3. I'm talking dozens of women that have shared these sorts of stories, or their mom that, didn't have the resources that they need and didn't understand anything better than to share their alcohol use disorder with their daughter. And, they grow up, addicted to alcohol. Those aren't choices that they made. People don't choose where they're born or who they're born to or what circumstances they're born into. Those are not choices. And we really need to provide people more grace, more empathy than that. And honestly, there's a personal responsibility that each of us have to our neighbors. And what about that personal responsibility? So that, I think that stigma piece is always going to be there. It's something that we still need to battle and address with science and facts. And that needs to take place with healthcare providers. There's still a long way to go with educating healthcare providers on narcotics and prescribing. I admit patients to 3 different recovery centers, and I am still shocked when patients are presenting on a benzodiazepine and a stimulant, both being prescribed by the same doctor. One's a downer, one's an upper. Why do they need both? I would challenge that they don't need either. But we're still seeing very odd prescribing taking place. And some of that just needs to be addressed with education. So having the prescription monitoring programs available now in every single state, I think is huge. So the doctors can look up and see what the patient is actually being prescribed and getting filled. But also in Indiana, we get feedback. So we get a report that shows us where our prescribing falls in relation to our peers. And, doctors are competitive. We want to be the best or in the group of the best. And so if we're told that we're prescribing more opioids or more stimulants or more benzodiazepines than our peers, oftentimes that's motivation enough to start doing something different. But I think those sorts of programs are really valuable and need to be replicated in other states that may not have that sort of thing. And then I think even more direct, contact from the licensor board or the health department to do a one-on-one sit down with some doctors and just help them understand that what they're doing is out of line with standard of care. I think that would be helpful. But more education in medical school on social determinants of health, that we talked about during the talk, I think is really important because it's those social factors that determines people's health. And I would even, go further and say to maybe even, rethink the Hippocratic Oath a little bit and stop thinking of do no harm and start thinking of protecting the people in our communities from harm, which requires us to get outside of the 4 walls of our clinic and start thinking of population health instead of just waiting in our clinics for people to come to us, doing more in the community with community health workers and those sorts of things. And then just more education on understanding the physiology of addiction and how it develops, the genetics of addiction, the understanding of epigenetics, that traits can actually be passed on to the next generation when they've been unlocked through toxic stress, through social determinants of health, and through access to alcohol and substances.
Wonderful, thank you. I just want to be respectful of everyone's time and thank you very, very much for this presentation. It was wonderful. And we will post the slides and this recording on the ATTC website. It probably takes about a week. So you can find it there in the product section. Again, thank you, Dr. Cooke. This was wonderful. And thank you everyone who joined us. We appreciate everyone's time and have a good afternoon.